Hello and welcome back. This is part 4 of the lecture on chapter 17, endocrine system, diabetes mellitus. We finished up part 3, looking at an acute complication of type 2 diabetes, and now we're going to change our focus to living with type 2, living with diabetes in general, and then some of the complications that can arise if the diabetes is not well controlled. The most important thing that I want to get across in this lecture is a message of hope. Having well-controlled diabetes is the leading cause of nothing. This is one of my favorite quotes about diabetes. This was specifically about type 1 diabetes by Dr. William Polanski, but it can also apply to type 2 diabetes. If the blood glucose is managed, and managed well, kept in the normal range, then patients can expect to have a very normal life. And again, we're replacing the blame and shame that is often associated with type 2 diabetes with hope and empowerment. So the quote goes on, the leading cause of nothing doesn't mean that nothing bad can happen, but with good care, odds are good that you can live a long and healthy life with diabetes. I'm going to show you a couple of graphs. These are tracings from continuous glucose monitors of a couple of patients. I know this is hard to see, but in a moment when I reveal the other graph, it'll be easier to understand. So what we're looking at here on the x-axis is time, and on the y-axis is blood glucose levels. And all these tracings, it's a bunch of different days superimposed on each other. But what you see is these blood glucoses stay very close to the normal range, very few of them dropping into the hypoglycemic range. This is often what everyone is afraid of when we say tight control of glucose. When somebody has tight control of their glucose, blood glucose, by managing diet and managing their physical activity, the amount of variability decreases dramatically. This is in contrast to what is typically done. This is a tracing. Again, time on the x-axis and blood glucose level on the y-axis. What's shown in green, that is the target zone. That's the normal blood glucose levels. And so what we're looking at is somebody who deals with dawn phenomenon, or foot on the floor phenomenon, which is first thing in the morning, blood glucose levels rise. They treat with insulin, blood glucose levels come crashing down. They go all the way through the normal range and crash down to hypoglycemia. Then they have to recover, getting glucose, or some people try to treat this with food, which is less predictable. And then they spend the rest of the day bouncing around from super high to less high, but still very high. Why this is the management strategy that's often recommended is because it looks like it's going to avoid the hypoglycemic episodes. But I think you can see that hypoglycemia is actually less commonly occurring here than it is with this patient, even though the average blood glucose is much higher for the patient on the right. Okay. So when I say well-controlled diabetes, what I mean is maintaining blood glucoses in the relatively normal range and staying here most of the time. What we're going to do for the rest of this is take a look at what happens when blood glucoses are not managed well, when the person suffers from hyperglycemia much of the time and hypoglycemia some of the time, but most of the damage is occurring because of the hyperglycemia. So this is chronic complications of uncontrolled diabetes mellitus. Just having the diagnosis of diabetes mellitus, type 1 or type 2, is not what's causing the problem. It's having the uncontrolled blood glucose. All right, so microvascular disease in a nutshell, we're getting endothelial injury. That is, the cells that line the inside of the blood vessels are getting damaged. This can lead to blood clotting. This is my child. Can you say hi? All right, so I'm going to keep recording. The mechanism of the damage is related to glycosylation of the molecules in the cell. Remember, we talked about the A1C values being the result of the glucose sticking to the hemoglobin. All right, similar things can happen to other cells, and it's not reversible. And there are other mechanisms of damage as well. Okay, blood vessels are getting damaged. That's going to have consequences all over the body, but there are 3 places in particular that it gets noted because there are 3 disorders that are associated with it. So let's take a look at those first. The first one, we'll start at the top and go down, retinopathy. So in the eyes, we have damaged capillaries that leads to retinal ischemia, so not enough blood supply to the cells of the retina. This is going to lead to visual disturbances, blurry vision, and ultimately to blindness. This is how some of our patients with diabetes end up losing their vision little by little because of the retinal ischemia. And it's directly related to the hyperglycemia that they experience. Another place in the body that we see problems occurring is in the kidneys. This is diabetic nephropathy. So once again, it's damage to the capillaries. Remember, this diagram keeps coming up. Afferent arterial, here's the ball of capillaries we call the glomerulus, and then the efferent arterial, the renal tubule. We're damaging capillaries. This glomerulus, remember, that's where a bunch of stuff is supposed to come out, like 20% of everything that's small is supposed to come out, but the big stuff is not supposed to come out, like the proteins, the albumin, for example, that's the antibody, they're not supposed to be coming out. But the capillaries end up getting really leaky, and we end up losing protein, losing albumin. And the other proteins, but albumin is the thing that gets measured, and that gets lost in the urine. And eventually this leads to the damage that we're getting in the capillary leads to scarring to the point that nothing is getting filtered. And that leads to chronic renal failure, decrease in the filtration rate. Remember way back when? Okay, so first sign of one of the first signs of damage is suddenly leaking protein into the urine. And that's why with the diabetic patients, we monitor their albumin levels in the urine. And then finally, the third place that we note the damage. And once again, it's happening everywhere, but these are the 3 places: in the eyes, in the kidneys, and in the nerves. We end up with neuropathies. So what's happening is we have compromised perfusion in the peripheral neurons. So you're not getting enough oxygen, so the cells aren't going to be making enough ATP. That's going to lead to decrease in the neuron or nerve function. So the good news is often what gets damaged first is the dendrites and the axons of the neurons. And you remember neurons, like there are certain cells of our body that end up in the cell cycle. Remember this, G1, S phase, and G2. Many of the cells of our body, some of the cells of our body, neurons and cardiac muscle cells, they get into G1 and they stay there for the rest of our lives. They don't reproduce. That's why we've said nerve damage and heart attacks are so deadly, because we can't recover from them because the cells won't replace themselves. Same goes for these neurons. The thing is, though, if the neurons are damaged but not dead, we can get repair. So we can recover from damaged but not dead neurons, but it's going to require months, or in some cases years, of controlled blood glucose. So people can regain sensation, they can regain some motor function as long as the neurons are still alive. There is hope. So what are the manifestations? What does this look like? I roughly separated it into sensory, motor, and autonomic deficits. Autonomic is going to include both sensory and motor. So these are sensory and motor deficits of things that we're aware of. So sensory deficits are going to manifest as tingling or burning, decreased sensation or numbness. This is why annually we check diabetic patient feet. We touch them and see, can you feel that? We're assessing the progress, the progression of the neuropathy. That's going to come up again in a little bit. Then the motor deficits, remember sensory information is traveling in towards the central nervous system. Motor output is going out, but it's still neurons that are affected in the same way. So we end up with decreased conduction velocity. We're not sending the signal as effectively. This is going to change the strength. So the person's still sending the sensation or sending the signal to the muscle, contract so I can walk, but the message isn't getting to the muscle cells. And so the patients experience a decrease in strength, decrease in muscle coordination. Their gait can be off. This contributes to how some of our diabetic patients get hurt more often. They fall more often because they can't feel where things are and they can't coordinate the movements as well once the neuropathy has gone on for some time. Those same principles apply in the autonomic nervous system. And remember, autonomic nervous system means it's the sensations that we're not aware of, the chemoreception, the sending signals to muscles that we can't consciously control, smooth muscles. So parasympathetic dysfunction can lead to GI problems, such as gastroparesis, that the stomach ends up not emptying predictably. This tremendously complicates the treatment of diabetes because, remember, if the patient is taking insulin, we need to coordinate the taking of the insulin. So I'm putting it in my shoulder. The taking of the insulin, so into the hypodermic region, going into the skin, and coordination of that with the intake of the food. Okay, great. So you've calculated how many carbs are in this meal and how much insulin you need. So inject the insulin, eat the food, and then the food just sits there. But the insulin doesn't just sit there. The insulin is going to do what it does. And so having this GI problem of gastroparesis tremendously complicates things. So it's best to not get to this point. There can be bowel alterations, and this depends on things moving too quickly through the GI system or moving too slowly. That's how we end up with either diarrhea or constipation or alternating these things. For a huge number of patients with diabetes, erectile dysfunction is a real thing. And that's results from a problem with blood supply as well as innervation. Again, an avoidable problem if the blood glucose can be managed. Sympathetic dysfunction also occurs. Remember, it's the sympathetic part of the nervous system that controls the contraction of the smooth muscle in the blood vessels, helps us maintain vascular tone, helps us maintain our blood pressure and control our blood pressure. Well, if the signaling is malfunctioning, both the input of, what is the blood pressure, or the output of, I'm supposed to be contracting these muscles, we end up with orthostatic hypotension. The person's not able to adjust their blood pressure as things go, as they move around in the day. And now, so that was all microvascular. Now let's talk about macrovascular disease, larger scale problems. The big problem here is atherosclerosis. And you'll remember atherosclerosis means we're getting stiffening of these arteries. We're laying down these plaques. So got this big lumen open here, and little by little, we've been damaging the endothelium. And in an effort to repair the endothelium, we start putting down the cholesterol, and this plaque just gets bigger and bigger. And then there is the risk of the plaque leading to the development of a blood clot, with further impairs flow of blood through here. So it's the high blood glucose that's causing the problem. It's causing the endothelial injury. That's what starts the process of the atherosclerosis. So the highest priority in treating our diabetic patients is reversing the hyperglycemia. Let's stop damaging the blood vessels. Remember, though, that type 2 diabetics, type 1 uncontrolled patients with uncontrolled blood glucose end up developing dyslipidemia. That's going to facilitate this. One of the reasons that people jump on the dyslipidemia is because dyslipidemia is easily treated with statins. That helps to bring down the cholesterol level, and it's very predictable. It's way easier to treat dyslipidemia than it is to treat diabetes. But the underlying problem is the hyperglycemia. That's the higher priority problem to treat. Okay, and as we've said, the plaques cause a reduction in blood flow through the arteries. It can cause complete blockage, but can also just cause decreased flow. And this can be a problem in the coronary arteries. It can be a problem in the renal arteries, all over the body. And continuing with this idea, clinical consequences, we said coronary artery disease, which of course, if the coronary arteries get blocked, that can lead to a heart attack. Just decreased blood flow to the cardiac muscle can result in heart failure. The heart can't keep up because it's not being delivered enough oxygen to the heart itself. The restricted blood flow in the brain can lead to stroke. And then in the periphery, peripheral artery disease can lead to a breakdown of skin and to the development of gangrene and eventually to amputation. This is the explanation for why so many of our diabetic patients end up losing bits of themselves. It starts with a toe, and then it's part of the foot, and then it moves upward. So increased risk of infection, also going hand in hand with the amputation. Why does it happen? Well, we have this high blood glucose. There is the micro and macrovascular changes from the hyperglycemia. So we're decreasing perfusion to the tissues, and we've got the skin breakdown. Then this is where the neuropathy comes into play. The patients have, and the retinopathy, the patients have impaired vision and impaired sensation. So some of our patients fail to notice when they have a wound, when they have an infection. They don't see it. This is one of the reasons that it's recommended that diabetic patients use white socks as opposed to black or any other color, so that in case there is some blood that is coming out, that it's actually easier to spot. Now, again, because of the high blood glucose, the pathogens multiply quickly because we're feeding them so much, lots and lots of glucose present. But then let's go back to the immune system that's supposed to protect us, right, from infection. But we've got two problems here. One, we have decreased perfusion. We've already mentioned that. That was why the tissue was breaking down in the first place. So we have decreased perfusion, so we have decreased delivery of white blood cells to the area. And then on top of that, the white blood cells that do get there, their function is impaired by this chronic uncontrolled hyperglycemia, which makes the development of infection and the taking off of infection much more likely. So here's a summary of what we've gone over. In clinical setting, now we said overall population, the prevalence of diabetes mellitus is somewhere around 10%, maybe a little bit higher in 2021. But in the hospital setting and in the clinical setting, roughly 20 to 50% of our patients have diabetes mellitus. And I say with an asterisk, 20 to 50%. I know that's a huge range. This is based on a completely unscientific survey I've made of my nursing colleagues. And in fact, in the discussion board for module 4, I've put the question for you guys, if you have a few minutes and have an estimate in your clinical setting or your clinical experience, what proportion of your patients would you say have either diagnosed diabetes mellitus or that you have to monitor their blood glucose while they're in your care? Okay. All right, so some fraction of our patients have diabetes mellitus. As you know, it's going to impact all aspects of their care and their recovery. People recovering from surgery are going to recover much better if their blood glucoses are not out of control because they have a wound. We need better immune system function to get those wounds to repair. We've mentioned the acute complications, extreme hyperglycemia. For type 1 diabetics, that'll include DKA. For type 2 diabetics who are still making insulin, that looks like HHNKS, the hyperosmolar hyperglycemic non-ketotic syndrome. And then patients who are receiving treatment may end up hypoglycemic if there's a mismatch in the treatment, getting the insulin level up, and their intake of food. And then the chronic complications are all from the compromised perfusion, heart attacks and strokes, amputations, and as we've said, the retinopathy, the nephropathy, and the neuropathy. Okay, I'm not going to end on that gloomy note, but I did want to make sure that point is driven home. Diabetes mellitus is an enormous problem in the population of patients that all of us deal with. But there is hope. This is a reprise of a slide you've seen before. Well-controlled diabetes is the leading cause of nothing, and we're replacing the blame and shame with hope. I'm going to get a little personal here. This is me in 2013 with my beautiful husband. I was a healthy person. I'm a healthy person now, but I was carrying around a lot of weight, and I did not know this, but I was probably hyperinsulinemic at the time. And it wasn't until I started nursing school in 2015 that I was diagnosed as pre-diabetic. And it was a nursing professor actually who was poo-pooing the idea of a low carbohydrate diet for diabetic patients. We were talking about an article that he had just read that recommended ketogenic diets for diabetic patients because they don't feel hungry on this diet. And I went, oh, I need to know more about this. And I looked into it, and there's some other things that happened as well. But things significantly turned around for me. And this is one of the reasons that I feel so strongly that our diabetic patients are not getting the information that they need, are not being empowered adequately. They're being told to lose weight, but they're not given the tools to lose the weight that they need to lose. For a lot of us with type 2 diabetes or with pre-diabetes, there is a problem processing carbohydrate. And we got there because there was a problem with the intake of carbohydrate that we had, and our bodies can't handle it. And we do need to change something. I was quite physically active at the time, but there was a mismatch with my carbohydrate intake and my physical activity. All right, so it doesn't mean nothing bad can happen having diabetes, but you can live a long and healthy life with this condition. Have a wonderful week.